you are able to find like the Barrett esophagus typically in case of long-standing GERD. And obviously, while having GERD, obviously there is a acid reflux in the lower esophagus, and this reflux is basically irritate the mucosa, right? So this irritation of this mucosa is basically associated with some kind of metaplasia. What kind of metaplasia? So our squamous cell epithelium that has been replaced by intestinal columnar epithelium. Why? Because this intestinal columnar epithelium is basically acid resistant in nature, and they are basically forming like secretory. There has been secretory granules which are basically known as what? Goblet cells. So these are basically resistant to the acid. So these columnar epitheliums are the resistant to acid secretion. And obviously this Barrett esophagus, why we are so much worried about this Barrett esophagus? Because there is a risk of adenocarcinoma. That's why we are so much worried about it. So obviously for the diagnosis you have to go for endoscopy. So what you are able to get while doing endoscopy, you are able to get red velvety appearance of this mucosa, but obviously this is a classical findings, but are not able to find this kind of findings everywhere, right? So if you are able to find red velvety appearance of the mucosa, then you have to go for what? Then you have to take the biopsy, right? So you have to take the biopsy. So in the biopsy you are able to get like the long segment which is more than 3 centimeter. It could be like the short segment which is less than 3 centimeter, obviously. And another thing is that microscopic Barrett. So your microscopic Barrett is basically which is also known as cardiac metaplasia. Like you are able to find like less than 1 centimeter deposits of the metaplastic changes, and these are basically known as cardiac metaplasia, right? So obviously when you are able to get the classical findings like the red velvety appearance of the mucosa, then you can deal with such a manner. But what happens if you are not able to appreciate this kind of abnormal mucosa by just simply doing the endoscopy? Then you have two options in your hand. So one is your chromoendoscopy, another is narrow band imaging. So what we do in case of narrow band imaging, we are using specialized or specific wavelength of lights. Wavelength of lights has been used for the filter of the mucosa or filter of the imaging, and that imaging is basically helps us to detect any abnormal mucosa is there or not. And obviously there is another way which is also known as the chromoendoscopy. While in case of chromoendoscopy, what we do, there are specific dye. So while applying this dye, we are able to recognize abnormal cells. So this like few specific dye are used to recognize few specific abnormal cells. Like your methylene blue is there. This methylene blue is basically helps us to recognize abnormal adenocarcinoma cells only. But in case of Lugol's iodine, it will also helps us to recognize the squamous cell cancer only. Obviously, after recognizing the abnormal cells or abnormal mucosa, you have to take the biopsy. But your biopsy should have been taken from all quadrants, and that too from 1 centimeter distance. So this is the basic criteria while taking the biopsy. Okay, your biopsy should have been taken from the all quadrants and at 1 centimeter distance, right? Our next thing is Barrett's. So while doing the Barrett's, you while surveillance, you are able to find a Barrett's esophagus in the histopathological examination. Then what you have to do? You have to go for 2 yearly endoscopic surveillance, and obviously this endoscopic surveillance is always complemented with biopsy. So obviously in the biopsy you are able to get four kind of features. Obviously your first one is Barrett esophagus only, so then you have to continue your part of the surveillance, you are supposed to continue. Then you can get low grade dysplasia and high grade dysplasia. These both low grade and the high grade dysplasias, they are basically associated with increased risk of cancer. Like they are not a malignant lesion per se, but obviously there is a risk of developing malignant lesion is there. So for that case you have to ablate the mucosa, right? So for ablating the mucosa you have two ways, like there is a two possible ways are there to ablate a mucosa. Your one is radio frequency ablation and second is photodynamic therapy. So your number one option is the radio frequency ablation, your number two is photodynamic therapy, right? So obviously radio frequency ablation is much preferred. Why much preferred? Because this is associated with the less stricture formation. That's why RFA is always preferred over the photodynamic therapy, or some cases argon laser as well. But if you are able to get like the adenocarcinoma of the stomach, then you have to go for esophagectomy. Or relevant management of the sEsophagus, right? Okay, so another thing I also like to highlight, like while ablating the mucosa, there may be a possibility that some kind of abnormal cells that may be buried. Like when you do the ablation of the mucosa, like the all dead mucosas are basically shed off and there is a formation of the new mucosa, right? New fresh mucosa. So while doing the ablation, like if you are able to miss some small bunch of the cells, abnormal cells behind, or you are leaving abnormal cells behind, so obviously they are basically get buried over the new mucosa, and obviously there is a remote chances of patient developing cancer. So obviously you have to take care of that as well, right? So this is our Barrett esophagus.